Hi, welcome back to Echo Diabetes in the time of COVID-19. I want to thank Dr. Rayhan Lal of Stanford University, who's a faculty in our program, for joining us back and to give us some updates about diabetes in the time of COVID-19. Dr. Lal had shared with us some of the research findings back in September. Rayhan, can you maybe share with us some of the take-home messages that we learned about diabetes in the time of COVID-19 and with regards to management? And then maybe after that, we can talk a little bit more about anything new and intriguing since that time.
Absolutely, Nick, and thank you for inviting me to give that presentation. It certainly was a lot of publications we went through to generate that. Um, so I wanted to start with your first item, which is sort of our take-home points, and this is from the conclusions of my original presentation. Um, so our first takeaway was sort of that there was no conclusive evidence that the risk of developing or catching COVID-19 was any greater for those with diabetes. Um, there has subsequently been a little work about the viral load when measured in people with diabetes. And so there are some ongoing investigations to see whether potentially one might be a more vigorous spreader of disease in that situation. But certainly the time to clearance tends to be a little bit longer, um, especially amongst those with hospitalizations. If someone with diabetes develops COVID-19, there's a lot of evidence that in hospital mortality and disease severity are worse. And that's been consistently shown and re-demonstrated in subsequent trials. So if you are hospitalized and you do have diabetes and COVID, the combination may make outcomes a little bit worse in the hospital. The good news from the outpatient standpoint is lockdown did not adversely affect glycemic control. In fact, might be beneficial to those who have poor baseline control. And this has also been replicated. So the good news for us outpatient providers is that we can still help our patients achieve a good level of control, even during these difficult lockdown situations, particularly with the help of technology. And the other point is that the current epidemic has been associated with high rates of DKA in new onset pediatric diabetes. We are seeing more and more that the presenting glucose on admission is a prognostic indicator for anyone, and that includes whether you had a pre-existing diagnosis of diabetes or not. And so this glucose hypothesis is gaining some traction, and we are awaiting results from additional studies on that. A big takeaway for me from doing this is that in the early stages of a pandemic, there are lots of opinions, lots of observations. Then you start to get some data, you make correlations, and you hypothesize. But when we did the presentation, that was the bulk of what we were seeing, was this initial sort of trying to come up with theories with the ways that things worked, trying to put it together. And so at the end of all this, I declared that we really do need to test some of these hypotheses, and if this glucose control can improve outcomes. And I think we have seen some of that since the presentation was delivered, with more and more evidence, at least, that in the beginning, if your glucose is outside of this particular range, you're more likely to experience poor in-hospital outcomes. I think overall in the COVID research, lots of interesting therapeutics being considered. Certainly, we are all very hopeful for a really robust vaccine. We are still waiting on that one. And In terms of therapy, there was a very promising but small trial of recombinant soluble ACE2, with the thought that if you inject someone with enough ACE2, then the virus might bind to that rather than the receptors on the lungs, the heart, the islet cells, where it attacks and infects the body. So will be very interesting to see if that becomes part of our practice in terms of treatment of severe COVID-19 disease. And other trials on convalescent plasma and other therapies are ongoing, but we haven't really seen a cure, so to speak. So more to come.
So in terms of management approaches for patients with complex diabetes on insulin, basically what you're saying is things don't change so much. You should really pay attention to hyperglycemia. What advice are you giving your patients?
Yeah, so that's a great question. I think one of the big takeaways for our patients, especially, and I do both the pediatric and adult side. One of the biggest things is that age is such a huge factor in disease prognosis here. So that people who are young, regardless diabetes, no diabetes, tend to do better than folks who are older. Now, obviously, there are always exceptions to a rule, but for our pediatric age diabetes patients without significant other comorbidities, things seem to be looking brighter. And really, we are concerned more for the older population, and of course, preventing infections in the young so that we can also prevent infections in the elderly group. In general, the advice for diabetes doesn't change. We still want to take our best efforts to optimize glycemic control without overburdening as much as possible.
Great. Thanks so much for that, Rehan. And once again, to dive a little bit deeper into this material, please feel free to go check out the recording of Dr. Lal's lecture on the website listed here. And once again, thank you, Rehan, for your time and for being a champion for diabetes in the primary care setting.
Happy to do it, Nick, and thank you so much.